Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Jain. Dr. Jain graduated from medical school at Delhi University, LNJP Hospital, New Delhi, India. He completed his residency at DC General Hospital in Washington, D.C. He did his fellowship at Michael Reese Hospital in Chicago, Illinois, and at Ochsner Hospital, New Orleans, Louisiana. Dr. Jain is board certified in internal medicine, cardiology, and interventional cardiology.
We are going to talk about, can you all hear me? Yeah, I think so. Okay, good. We're going to talk about basically diabetes and how it affects the heart. And it's quite a long lecture, and I'm going to try to do it in the next 40 minutes or so and leave the last 10 minutes for questions. So basically, all of you probably understand that diabetes is a progressive disease which your body doesn't make or respond properly to insulin. So it's basically related to insulin issues. Insulin is a hormone that is made in the pancreas. It is used to convert sugars, starches, and other food to energy. If you have diabetes, your blood glucose or sugar levels are too high. Diabetes is defined as a fasting blood glucose of 100 milligrams or less or more measured on 2 occasions. This is fasting blood sugars. And this definition has been changing over time. Over the last 5 to 10 years, the number has been decreasing and is becoming more stricter. The reason is because diabetes is a very important issue that we all are pretty much dealing with. It's getting to be much more common disease, and it does affect the whole body, not only the heart. So it is a huge problem, and that's why there's a stricter control of blood sugars so that you can prevent these problems. There are 2 kinds of diabetes, type 1, which appears at younger ages, and in this the pancreas stops making insulin, and without insulin injections the patients would not survive in type 1. In type 2, which is the more common one, it is an adult onset and appears in middle-aged adults generally. It develops when the body doesn't make enough insulin, or if it makes insulin, then it is an inefficient insulin, so it doesn't work well, and that's called as insulin resistance. The prevalence of diabetes in adult population by year and region, you see that it's not a disease of the poor or undernourished or underdeveloped countries. It is more of a disease of a developed country. So we see it more in the United States, Europe, rather than in Asia. And you see that the incidence is increasing. In 1995 to 2000, there was a few percent point increase, but by 2025, we expect another 8 to 10% increase, another 1 to 2% increase in patients having diabetes. Now, this is the definition of diabetes, basically. Fasting glucose more than 100 or a 2-hour post-glucose load of more than 140. And impaired glucose tolerance is when the blood sugar is less, impaired fasting glucose is 100 to 140, and impaired glucose tolerance is anything more than 140. So those are the definitions. Now you could understand another disease which is called as the metabolic syndrome, and it is more associated with weight issues. So obese people, they develop insulin resistance and increase in free fatty acid. This is a part of the fat metabolism that occurs and is created in the liver. And what happens in this, because of the obesity, there is issues with blood sugars. There is issues with cholesterol problems, low HDL, small dense LDL, and there is issues with high blood pressure, as well as there are issues with inflammation and clotting of blood. So this whole syndrome is because of overweight. And it is affecting all the components, all the risk factors of heart disease. So one has to recognize this, and the way to treat this is by treating the weight issue. So one recognizes this problem because it is shown that metabolic syndrome, people with metabolic syndrome have higher incidence of cardiovascular mortality. They die more so because of heart disease than patients that do not have metabolic syndrome. Okay. So how dangerous is diabetes? Diabetes kills over 60,000 Americans each year at least. 190,000 die from diabetic complications per year. Leading cause of blindness, that is 12.5% of the diabetics will end up having the problems with eyesight. Leading cause of renal disease, 42% of patients develop that. 50% of all non-traumatic amputation, that means amputations of the legs happens because of diabetes. 2.5 times increase in risk of stroke, 2 to 4 times increase in heart attacks. It is responsible for 25% of the cardiac surgeries, that is bypass surgeries, and mortality in diabetes is 70% due to heart disease. So it is a big issue and causing a lot of problems. This slide shows that diabetes and heart disease mortality over 20-year follow-up. Patients with diabetes have double the chances of dying from a heart attack than patients with no diabetes, even that is equal in men and women. This shows that the major cause of death in diabetics is heart. 40% of the deaths that occur in patients with diabetes is because of heart attacks or heart-related problems. Shows that if we control diabetes, that is the measure of diabetes these days is A1C, and it should be less than 6 to be absolutely normal. Less than 7 is somewhat acceptable. And if you see that if the A1C goes up by 1 point, the chances of having heart failure or death due to heart attack is 1.3% more. And similarly, if it goes from 8 to 9, it increases further, and more than 10 A1C, the risks are very high, almost 9 to 10% of dying of heart attack. Okay. On the other hand, if you were to decrease the A1C, that is, if you control your diabetes well, every 1% decrease in A1C would result in 21% decrease in any of the diabetes-related endpoints. That means problems with the eyesight, problems with the kidneys, problems with the heart, problems with the leg circulation. They will decrease by 21%. Decrease in risk of heart attack by 14%. Decrease in risk of stroke by 12%, and decrease in risk of microvascular complications, which I'll tell you in a minute, is 37%. So every 1% decrease in A1C does help a lot. Diabetes affects from head to toe. And these are the macrovascular complications. These are microvascular complications. The difference is you're talking about the arteries, the big arteries being affected or the small arteries being affected. When the small arteries are affected, these are basically in the eye region, so it causes retinopathy and cataracts. Kidney arteries get blocked. These are smaller arteries that causes kidney failure. It causes erectile dysfunction. It causes peripheral neuropathy. On the macrovascular side, it causes strokes. It causes heart attacks, heart failure. It causes blockages in the leg arteries and causes gangrene, and it causes foot problems. Okay. This is an angiogram of a patient who has diabetes, and what I'm going to show you here is this is the main artery to the heart, and this is clogged up right there, right here. Okay. This is in the heart, but same patient with diabetes, looking at this is the patient with the same patient has kidney artery blockage, both sides. And these are the legs. leg artery blockage. So it had major problem with the heart, has major problem with the legs. And this same patient has neck artery blockages. You see this neck artery blockage, and has blockages in the arm arteries. So what I'm showing you here is diabetes just does not affect one part of the body, or does not just affect the heart. It's affecting you from head to toe in the circulation area. So when you check a diabetic patient, you just don't check the heart only, you check them from head to toe. How is heart disease different in diabetes? There is definitely more heart disease in diabetes, and it involves more arteries than less arteries. That is what is multivessel disease. It involves not only the big arteries, but it involves the smaller arteries also. So when the smaller arteries are clogged up or blocked, then it becomes very difficult to open these arteries, because opening the big artery and downstream, if the blockages are there, doesn't help, because the tissue still does not get blood. So that is a problem with diabetes. It causes silent ischemia. That means you may have a heart attack but have no pain, which is typical of heart attacks. Patients with heart attacks have pain, but patients with diabetes may not have any pain because the nerves get destroyed. And when these nerves get destroyed, there's no pain involved. So you may have a heart attack but not know about it, or you may have a big heart attack as a sudden one-step thing, and you may get short of breath, or you may not survive that. Okay. In diabetics, the disease occurs in a younger population rather than older population if they're non-diabetic. It is more common in women to have heart problems with diabetes, and the worst outcomes, despite opening of the arteries, happens with diabetes. Okay. So how does the heart disease occur? It is basically called as a process of atherosclerosis. It is progressive buildup of plaque on inside of the artery wall, and mainly in the large arteries. That is what is atherosclerosis, buildup of plaque. There is another term called as arteriosclerosis. That is hardening of the arteries. That is not building up of the plaque, and it is basically thickening of the arterial walls. And this happens more with age, happens more with high blood pressure issues rather than building up of the plaque, which is seen more often with diabetes. So atherosclerosis is the lesion of the large and medium-sized arteries with deposits in the intima, that is the inner lining of the arteries, of yellowish plaque, which is composed of cholesterol, lipid material, and some blood cells. The hypothesis is that the way it develops is because the inner lining of the arteries somehow gets damaged, and once it gets damaged, this process starts. And normal artery has 3 linings. So it has, normal artery has 3 linings. Basically, it has the inner lining, which is 1 cell thick, called as endothelium, the middle lining, which is muscular layer, called as media, and the outer lining, which is fibrous tissue, called adventitia. The inner lining is the key. When this inner lining gets damaged, then the process of atherosclerosis or the plaque buildup starts. And it is thought that this inner lining gets damaged because of all these risk factors, the high blood pressure, diabetes, and cholesterol issues. So once the inner lining gets damaged, then all these sticky cells and all come through this lining into the middle lining and start the cholesterol. If your cholesterol is high, then the cholesterol particles diffuse from the blood into this area of the inner lining, and it starts building up. And as it builds up, this yellowish material under the lining, this keeps growing, and it accumulates with cells, it develops its circulation. Once the circulation is not able to support all these cells, then that is when it ruptures, it breaks open. And this breaking open of the lining because of the pressure causes the liberation of all this yellow material, the sticky material, and the cells. When this happens, then it can cause 2 things. One is completely block the artery. If it completely blocks the artery, then it causes the heart attack, strokes, gangrene. On the other hand, if it does not completely block the artery, then it causes a blockage, which is maybe 70%, 80% or something, which decreases the blood flow downstream to the tissue. And if there is less blood flow or oxygen or the food material to the tissue, the cells start dying. And that is when you get symptoms of chest pain, but not a heart attack. You may get symptoms of weakness of a slurred speech, but not a complete stroke. But those are all warning signs. So that is how this process takes place, by buildup of this material under the lining, the one cell lining. And this shows how the process occurs completely. Okay? And this is the kind of material that gets liberated when the lining ruptures. So what are the causes of atherosclerosis? What are the risk factors? There are 5 major risk factors, and these are high blood pressure, cholesterol issues, smoking, diabetes, and family history, which is genetics. There are minor risk factors, which are called as secondary risk factors, and those are overweight, obesity, stress, sedentary lifestyle, age, and definitely there is a little preponderance to female sex than male, and race. So let's go over the risk factors. I'm going to go over the major risk factors first. Diabetes, basically we've talked about it a little bit before. Blood sugar should always be less than 100 generally. 100 to 140 is somewhat acceptable, but it should be always less than 100. Diabetes is one of the worst risk factors. It is thought that if you have diabetes, you are put in the same category as patients who've had a heart attack. So heart attack and diabetes are in the same category. You need for aggressive control of risk factors when you have diabetes. That means you have to control the other risk factors, because the other risk factors compound the problem. And there's need for frequent and complete heart and circulation evaluation in patients with diabetes. High blood pressure basically has 2 components. One is the systolic, the top one, and the diastolic, which is the bottom one. The top one should be always less than 120 to 140. It varies with age. As you grow older, like I told you, the arteries get stiffer. When they get stiffer, the blood pressure creeps up. So in a patient who is 80 or 90 years old, 150 blood pressure is acceptable. But generally, if you are in the 70 or less, the blood pressure should be less than 140 on the top one. And the bottom one should always be less than 90. Okay. This is the blood pressure. The higher the blood pressure, there is more damage to the lining of the cells. And that is what it is thought, that blood pressure is one of the major culprits of damaging the lining and causing the start of that process of atherosclerosis. Hyperlipidemia, the cholesterol problems. I call them the good, the bad, and the ugly. The good cholesterol is, as you know, the HDL. The bad cholesterol is the LDL, and the ugly is the triglycerides. There are many other factors these days that have come into that people talk about. But if you remember these 3, I think you will do quite a bit of good to yourself. Cholesterol should be always less than 200 if no previous heart disease or diabetes. But if you have previous heart disease or diabetes, then the cholesterol should be less than 150. Okay. The good cholesterol, which is called as HDL, should be more than 40. Helps clean up the arteries of bad cholesterol, and it generally goes up with exercise, the HDL. The bad is the LDL, and it should be less than 130. But if you have heart disease or diabetes, then it should be less than 70. It goes down with diet and exercise. Both help. And it has a lot of other components that we talk about these days. But this is still the major one. And if you can keep it below 130 or below 70, depending on what category you fall in, then I think that is more than enough. The triglycerides, they go up and down with diet and are related acutely to what one eats. So if you've had a heavy meal the night before, you get the blood test, the triglycerides will generally be high. So they do get affected very acutely. On the other hand, the LDL and the HDL do not get changed that fast. Triglycerides should be less than 150 all the time, and it does go down with diet. Okay. In diabetics, what we see is these are the things that happen. The good cholesterol goes down with in diabetes, the triglycerides go up, the bad cholesterol goes up, and there are other components that get affected. So you see that the diabetes is messing up your cholesterol completely. It's messing up your good cholesterol, messing up your bad cholesterol, and your triglycerides. So if you control diabetes, you will get a better handle on your cholesterols also. Smoking, there is really no discussion that I have. There's no advantage of smoking, no excuses at all. On the other hand, if you have more than one risk factor, the chances of having heart problems increases. If you have no risk factors, chances that you'll get into trouble is less than 5%. On the other hand, if you have one risk factor, the chances are anywhere from 5 to 10%. If you have two risk factors, it goes up to 10 to 15%. And if you have three risk factors, it's 15 to 20%. On the other hand, if you have diabetes along with these risk factors, you can see that you double your risk at every category. So diabetes affects the risk factors very significantly, especially if you have other risk factors too. And you would see that most of the patients who have uncontrolled diabetes will have issues with high blood pressure, will have issues with cholesterol. And most of them will also have family history. So when you have four risk factors, that is family history, cholesterol, diabetes, high blood pressure, and if you smoke, in my books, you're a walking time bomb, because you will have an event in 5 to 10 years' time, almost guaranteed. So there is a ticking clock hypothesis which says that if you know that you have diabetes, then at the onset of blood sugars that have started to creep up, the microvascular complications start. Like I showed you, the eyes, the kidneys, they start when the blood sugar starts rising. On the other hand, even before the blood sugar starts rising, you have the diabetes genes, or the diabetes is affecting your body, even if before the blood sugar goes up. And that is when it's affecting your heart, your arteries in the brain, your arteries in the legs. So diabetics are prone to have problems even before the diagnosis is made. What are the symptoms of high blood glucose? Basically, one is, we call them as polyphagia, polydipsia, and polyuria. You feel more hungry, you drink a lot of liquids and water, and you urinate more often. So those are the cardinal three signs of diabetes. And then weight loss, fatigue, blurry visions can be associated with it. Now in heart, like I told you, that mainly it is the heart pain, which is typically called as angina. If you get chest pain, which is typical of angina, that is coming from your heart, and that is because there is poor circulation to the tissue, the heart muscle, and the heart muscle is dying, and that is what causes the pain. Now there is a typical pain which is pressure, tightness, squeezing, heaviness, or choking right in the middle of the chest. Those are classic symptoms, but they happen very rarely in diabetics. Diabetics do not get this severe pain as normal persons, people with non-diabetes, and more often patients with diabetes will get shortness of breath, fatigue, inability to walk or do things. So they are non-specific symptoms. So hence the diagnosis of heart problems in diabetics can be missed. And that happens in about 30 to 40% of the patient population. Not every diabetic the symptoms are silent, but 30 to 40% of the patients will have silent ischemia. The typical chest pain radiates down the left arm or to the back or to the jaw, and it occurs with physical activity, emotional stress, cold weather, and lasts for a few minutes or until the activity ceases. How do you diagnose heart disease? It's typically physicians or clinics would do ECG, And if the ECG is abnormal, they go on to the next step. That is quite a misnomer. Doing an electrocardiogram really doesn't tell you your risks of having a heart attack. Doing an electrocardiogram in an office just tells you whether, and that too about 70 to 80% of the time, that will tell you whether you've had a heart attack or not, whether the damage is done or not. So it will tell you the past, but does not predict the future. So EKG is good. It's not a wrong thing to do, but to stop with EKG in a patient with diabetes, I think is not right, because you really haven't told the patient what are the chances of having a heart attack in the near future. So to do that, you have to do a stress test. Stress tests can be various kinds. They can be the treadmill kind test. They can be the tests that we do with giving medications. They can be with ultrasound, or they can be with the nuclear scan. So there are various kinds of stress tests, but the stress test really predicts what are the chances of your having a heart attack, or how much blockages, whether you have significant blockages or not. So stress test is the test that needs to be done in most of the diabetic patients, especially if they have other risk factors. Then once the stress test is done, then you go to the next step. This is just a cartoon showing that if you put up your clinic on a hill, then walking up to the clinic will be a stress test enough. Okay. So this is the kind of ultrasound stress test. You do basically, you take pictures of the heart. This is a nuclear kind of scan that you do, which tells you which areas of the heart are not getting enough blood when you look at it in different views. And then there are CAT scans that you can do these days, CT scan angiograms, which will tell you whether there are blockages or not. There are MRI scans that you can do, which will show you whether there's problems or not. And the gold standard is basically doing an angiogram of the heart, which is going from the groin, passing a catheter up to the heart, injecting the dye, and taking pictures. That is still the gold standard, and there may be issues with this gold standard, but till date, this is the gold standard. So one of those tests is what you need to really stratify you whether you are at a risk of having a problem with the heart or not. Now, how do you manage the heart problems that occur with diabetes or all the risk factors? The mainstay is diet, exercise, medicines, and then we have ways of opening up the arteries, which could be percutaneously or with surgery. Okay. So on the other hand, when you talked about the metabolic syndrome, that is the overweight issue, and the management of underlying causes, that means weight control, it helps with controlling the bad cholesterol and all the other risk factors. Also, if you exercise, that controls the weight, and it decreases the bad cholesterol, and it increases the good cholesterol. So weight control and exercise are the mainstay of managing the metabolic syndrome. Then you treat the lipid and the non-lipid risk factors. Lipid is basically taking medicines. You control high blood pressure. You control the cholesterol issues with medications. Okay. The weight loss has been shown that it helps a lot. It reverses the changes of insulin resistance and metabolic syndrome. By just losing weight, you're helping yourself a lot. And losing weight also raises the good cholesterol. So it can see an increase of 1.6 milligrams per deciliter from a 10-pound weight loss. So weight loss does help a lot. Now, there was a major study that was done to check if you had your therapeutic lifestyle change. That means you modified your lifestyle very aggressively and actively, then would that help you? That is what this study was about. So there were diet changes to improve cholesterol profile, there was daily physical activity, there was weight control, and what they found in this study, it is the Finnish diabetes prevention study that they addressed this issue in. And they did individualized counseling, they did reducing weight issues, and increasing the uptake of fiber and increasing the physical activity. So they addressed all these issues, and what they found that after 4 years, the risk of diabetes was reduced by 58% just by treating by doing diet, exercise, and weight control. Okay. So you decrease the risk of diabetes by 58%. And so that was a tremendous change. And that is what this study showed. So what they showed that about 9 pounds decrease in the diet and exercise group compared to 0.8 kilogram decrease in the usual care group. So if you're aggressive about watching all these things, you can effectively reduce 9 pounds at least. And that showed a major difference. There is another study that I want to share with you. It's called the reversal trial, which shows that if you treat your cholesterol aggressively, then you can make a major difference. And what they did in this study was they gave either 40 milligrams of pravastatin or 80 milligrams of atorvastatin, this is Prevacol, this is Lipitor. Some of you may know these. And they gave these to patients who had moderate cholesterol issues. And they watched over 18 months, and they looked at the plaque inside the artery. They went inside the artery, human arteries, and did ultrasound imaging. This is the inside of the artery. So you go into the heart artery, and you're looking at the heart artery from inside. So there are blockages like this inside the heart arteries. And what they did was they looked at baseline, and after aggressive treatment of cholesterol, they rechecked it and see what happened to these blockages. And what they found was that when you gave pravastatin, you decreased the LDL level. Remember I told you about 130? From 130 or above to 110 on an average with pravastatin. And since Lipitor is much more stronger medicine and was given in a higher dose, it decreased the LDL, the bad cholesterol, down to 79. And in terms of reduction, there was a 25% reduction with pravastatin and a 46% reduction with atorvastatin. And what it did was that pravastatin, the atheroma volume, that is the plaque volume, increased by 3%, though it still increased, though the cholesterol dropped. But with atorvastatin, where the cholesterol drop was very significant, the blockages decreased. A small percentage, less than 1% or 1% or so, but the blockages decreased. And what happens is that when I showed you this slide of this blockage increasing, causing pressure and causing rupture of the lining, once the blockage decreases, not does it decrease, the liquid in this becomes hard, solid. So when this becomes solid, the solid does not exert a pressure, and it does not cause this rupture of the lining. So if there's no rupture of the lining, there are no liberation of all this material causing the blockage. So if this becomes hard and solid and this does not rupture, then there is no heart attacks, there are no strokes. Okay? So basically, if you lower the cholesterol significantly, what you do is you change the plaque. And changing the plaque helps you even if it does not decrease significantly. But on the other hand, if this plaque keeps building up, then one of these days it will rupture and cause the heart attacks and strokes. So that is what this shows, and this study also shows that when you are aggressive about decreasing the cholesterol, you change this enzyme, which is called a C-reactive protein. This is an inflammatory marker. So by decreasing the cholesterol, you decrease the inflammation also, and that causes less issues with heart attacks and strokes. So basically what it concludes is that intensive lipid lowering with medicines reduces atherosclerosis progression versus the pravastatin. Patients treated with stronger medicines had no change in atheroma burden, whereas those with not had progression of atherosclerosis. So the key is that you want to control it aggressively. You want to reach those target levels that I talked to you about. Strategies for reduction of diabetes complications, the microvascular complications, you want to aggressively screen them, and you want to improve the metabolic control. And the macrovascular complications, you want to control the sugars very well. You want prevention of type 2 diabetes, aggressive treatment of established cardiovascular risk factors in diabetics and possibly pre-diabetic subjects, and diabetic agents that improve cardiovascular disease risk should be used. This is a study that I'm going to go to basically the crux of the study. It is talking about intensive control of glucose on cardiovascular outcomes and death in patients with diabetes. So if you control blood sugars very aggressively, then you can decrease the risks of all these major side effects, that is the heart attacks and strokes. That is what all these studies have shown over time. Whereas if you do not work at it aggressively, then you do get some benefit, but not major benefit. So the probability of events of stroke is decreased considerably if you are aggressive about controlling diabetes. And similarly, probability of events of all-cause mortality does not change. So it is going to decrease the risk of heart attacks, it is going to decrease the risk of strokes, but will it decrease the total death that occurs in the population is not sure. And that is what this database showed. So intensive compared with standard glycemic control significantly reduces heart attacks without an increased risk of death. So death can occur because of other causes. So that is what that data showed us. So let's talk about a few medications. There is effect of aspirin. My take is that every diabetic should take aspirin. Like I showed you, that they have more thickened blood, their chances of having clots are much higher with diabetics. So aspirin will help diabetics no matter what. That is my feeling. Not everybody shares that those ideas, but my feeling is that every diabetic should take aspirin. As low as 81 milligrams is good enough, because aspirin has been shown to decrease the chances of having a heart attack significantly in diabetes. You see the red line here is patients with aspirin, and their survival is higher than the blue line, patients with no aspirin. Whether you have diabetes, with diabetes, you're seeing that, and without diabetes, the effect is less without diabetes, a little bit more with diabetes. So diabetics, aspirin does help more. Similarly, there is a group of drugs called as ACE inhibitors. These are like lisinopril, Diovan, losartan, all these drugs. They are shown to be very helpful in diabetic populations. They decrease the risk of kidney problems in diabetics, this group of drugs. They decrease the risk of having heart attacks. And there is a recommendation from ADA that all diabetics and hypertensives should be on these group of medicines. I will tell you with one caveat, as much as we say that everybody should be on these medicines, medicines do have side effects and have issues. So you do have to look at the whole picture when you prescribe these medicines, but in general, these medicines do help. So aspirin and ACE inhibitors are very helpful. The third group of medicines that is helpful is called as beta blockers. They have shown to decrease the risk of dying from a heart attack if you are on this group of medicines. These are called as beta blockers, and these are atenolol, metoprolol, that group of drugs. They have always shown to be very beneficial in preventing death from heart attack. Okay. Overall, this shows that if you are treating patients aggressively with diabetes, intensive therapy, you decrease the risk of any of these events, that is the heart attack, strokes, and gangrene, if you're aggressive about treating diabetes. Now, there are percutaneous interventions, that is going into the artery, opening up the arteries, blockages with balloons, roto-rooters, cutters, and the way it is done is you cross the blockage with a wire, and then you put a balloon where the blockage is, you inflate the balloon, you smash the blockage against the wall, so you open up a channel basically, and you plaster that plaque against the wall. So you have not got rid of the plaque, and if you need to put a stent to scaffold that blockage, then you line it with a stent, and now you stretch the artery and open up a channel. But you've got to remember that all you've done is open up the channel. You have not taken care of the disease. So you have bought some time, basically. The disease will come back over time. How much time? It depends on what kind of device we use, what kind of drugs we use, but it is buying time. Whereas as I showed you in that Finnish study, that if you lose weight, exercise, diet, you have much more of a permanent effect. We have cutters, roto-rooters, lasers, stents, you name it. A plumber carries it, we carry it. So we have all the tools that we need to open up the arteries. Nowadays we have ultrasound guided opening up the arteries. We can go see what we are doing and fix it. There is angiogenesis, which is basically genetic material that we can put into the heart muscle, we can put into the arteries and regenerate the heart muscle. That is still a ways, so don't expect us to be doing that tomorrow, but that is in the pipeline, those kind of inventions. This is how you put the delivery into the heart muscle. If it is dead muscle, you regenerate it. So all this is in the works. Diabetes doubles the risk for MI mortality despite advances in cardiac care. What I'm telling you is that we have all these advances. We've done very good. We've decreased the deaths from heart attacks. We've decreased the risks of having a heart attack. But still, diabetes doubles the risk for MI mortality. Basically, what is happening is that 1962, there were a lot more patients dying. And these are with diabetes, these are without diabetes. And the diabetes deaths were more. The ratio remained the same. The amount of deaths that are occurring is much less. We are saving a lot more people, but diabetics are still at twice the risk as non-diabetics. Okay. Stenting in diabetes, opening of the blockages in the diabetics, the angiographic outcomes, what has been shown that our results are poorer in diabetes in terms of the blockages coming back or in terms of having complications. Diabetic population has more complications, more blockages coming back than non-diabetic population. So the ADA standards of care is they recommend a general A1C target of less than 7%. The goal for therapy for individual patient is to achieve an A1C as close to normal, which is 6%, as possible without hypoglycemia. That is major. So you don't want to have low blood sugars. If you were to choose between low blood sugars and high blood sugar is safer. Okay. Low blood sugars can cause strokes in terms of they can comatose you, and that can be dangerous. High blood sugar will not kill you immediately. So low blood sugar can. So you have to be careful with that. More stringent glycemic goals may reduce the risk of serious diabetes-related complications, but you have to be careful. And less stringent treatment goals may be appropriate for certain patient populations and patients with severe or more frequent hypoglycemia. So you have to take it with that caveat. So what are the pearls to take home? Early diagnosis or even preempt diagnosis. If you have risk factors, if you're obese, you have a strong family history of diabetes, chances of your developing diabetes is very high. So you start treating before you even get high blood sugars. So you can delay the onset of diabetes. And that is what is called as early diagnosis or even preempt diagnosis. Aggressive management of diabetes. If you have it, you treat it aggressively. You need a complete checkup in terms of physical exam, identify every organ involved, whether the brain is involved, the heart, the kidneys, the legs, everything should be checked properly. Frequent blood tests should be done. Even if you do not have diabetes or if you have diabetes, definitely you need to do these tests. And if you know that you have diabetes, do not procrastinate, avoid denial, seek help, sooner the better. Time prevents complications. So can you prevent heart attack in diabetics? My answer is yes. The question is whether you want to or not. Thank you.
You made the statement that if you have a strong family history of diabetes, that you should treat it before you even have high blood sugar. Now, what would you be treating? If you're not having any high blood sugar, what are you doing?
See, you may have high blood pressure, you may have high cholesterol, you may be overweight, you may have lifestyle issues. So you want to address those even before you are diagnosed as having diabetes.
Okay, I mean, I guess I was just assuming if you had high cholesterol or high blood pressure, you would treat that anyway.
Yeah, but aggressively. See, one is treating it in a leisurely manner and saying, okay, 6 months back, again, I'll get another checkup of cholesterol and see how things go. On the other hand, the other is, no, we want to get it better in the next few weeks, few months. So it is a much more aggressive attitude.
I understand.
Okay.
I was just wondering if statin medications cause diabetes.
No, not known till date. Statin medicines do not cause elevated blood sugar or affect the diabetes per se in any major studies. There may be anecdotes here and there, but no major studies have shown that it causes diabetes. The statins cause a lot of other issues, but not diabetes.
Could you tell us what other issues?
Basically, they cause muscle aches, cause some liver issues. They can cause some issues with basically it is called as myopathies, myositis, inflammation in the muscles and stuff, but not any other major problems that I know of. But they are very beneficial. These drugs are quite good when taken for the right reasons.
In all this scenario, what is the effect of moderate alcohol related to diabetics, strokes, and whatnot?
See, the question is moderate. The key word here is moderate. Basically, anything, a glass of wine, 30 mLs of any kind of alcohol, that generally helps. That's the thought process. Because what it does is it increases the good cholesterol. It does not in any way harm. But when you exceed those limits, then it starts harming by affecting the liver. Okay. So mild to moderate use of alcohol is not harmful in any way. Will it help? Most likely it does.
My problem is that I have low blood sugar, and you said that's even more dangerous than high blood sugar. And obviously I do what I can to control, but I still have a lot of drops down into 50 and even occasional 40s. What I'm interested in is, does this provide extra stress on the heart, or is it just more of the same?
See, low blood sugar, dangerously low blood sugar is less than 40-50. What it does is it makes the catecholamine kick in. This is epinephrine, adrenaline, stuff, those kind of things. They cause the heart rate to go up. So yes, low blood sugars can stress the heart. Okay, and low blood sugar, that is why it's more dangerous, because it causes these hormones to kick in, which makes the heartbeat goes fast. Heartbeat going fast damages the heart muscle. Not only that, it can cause irregular heartbeats, and that is how the things can happen. So, yeah, but the cause is not diabetes. The cause is other causes.
On one of the graphs that you had there, it was showing that it seemed like the generic Lipitor was a good thing for the diabetics. I mean it did reduce sometimes the plaque that had formed?
What that study was showing is that if you're aggressive about decreasing your bad cholesterol, then you can reverse or stabilize the plaque.
Okay.
So they used two drugs, atorvastatin and the Pravachol, but anything that would decrease the cholesterol, the bad cholesterol, by that much percentage would help.
Okay.
So the message is that
And those are those statins that people were asking about, the cholesterol reducing medications?
they are for LDL, they are thought to be the best ones today.
Okay.
Okay, but if you were to decrease the same percentage of LDL by diet, exercise, and doing the right things, then you don't need that much medicine, or you may not need the statin.
Right.
The key message over there is decreasing your bad cholesterol significantly with whatever way you can.
Right, right. And I mean, my understanding too is if you need to take some of those statin medications, you can also be having blood tests done that will tell you if there's any problems with the liver. So, I was sitting there thinking, oh gosh, should I not be taking a statin? But
No, taking it, like any medicine, you got to take it for the right reasons.
Right.
And then only will you get the benefit.
Okay.
So if you cannot get your cholesterol, the bad cholesterol down with diet, exercise, and losing weight, then you have to go on medicine, and statin is a good choice. There are others, but statin is not a bad choice at that point.
Okay, and I have one other question. Right after we were talking about the statins, you'd mentioned the beta blockers being, but the statins are not the beta blockers, and I can't remember, there was something very positive about beta blockers, but are those are for high blood pressure? Or what is a beta blocker?
Beta blocker is a group of medicines that help with the blood pressure, help with increasing the efficiency of the weak heart muscle, and they help with the irregular heartbeats. So that is a group of drug that has been shown that they prevent death. If you were to have a heart attack, 50% of the patients do not survive the heart attack. But if you are on a beta blocker, chances of you surviving is better than if you're not on beta blocker. So that is what the message is from there.
Okay, it was just such a quick switch from statins to the beta blockers. I wasn't sure what beta blockers were.
Basically, what I was showing was that there are three groups of drugs that really help. One is the aspirin, the other is the ACE inhibitors, and the third is the beta blockers.
Okay, we're come to time here. Thank Dr. Jain, and you did get your